We'll move to our second presentation. Dr. Andrew Healey is going to summarize for us our inaugural masterclass in donation, which occurred as a pre-conference event yesterday. Andrew is a specialist in emergency medicine and critical care and division head and medical director of critical care at William Osler. He's also our chief medical officer for donation at Trillium Gift of Life.
So thank you for this opportunity to talk about our inaugural masterclass for donation physicians. We held it yesterday. This masterclass sought to explore and develop the complexities and tensions that occur around the time of withdrawal of life-sustaining measures in people who are consented for donation after circulatory determination of death. I receive a salary support as the Chief Medical Officer for donation for TGLN, and I don't have any other conflicts to declare. I want to start by thanking this incredible group of people from the collaborative efforts of Trillium Gift of Life Network, the Donation Physician Network, and Canadian Blood Services in coming together to create an agenda that really aimed to get a very honest, at times quite heavy conversation out into the room, and I hope this sets the panel up for some difficult questions, especially since I'm not sitting on the panel. So at the master class, our target audience really was donation physicians and bedside nurse practitioners who were involved in the practice of withdrawal of life-sustaining measures in the context of DCD. We had, as you can see, a large group of experts in the audience to help contribute to that conversation, to help bear witness the experiences that they had at the bedside. And I think that contributed to the richness of our conversation yesterday. We came together with really a shared purpose, that is to develop that shared understanding I spoke about, particularly focused on patients who have consented to DCD following withdrawal, and to promote the implementation or discuss the implementation of WLSM guidelines in DCD hospitals. So in 2016, the Canadian Critical Care Society supported the work of James Downer and his colleagues to develop and publish the guidelines for the withdrawal of life-sustaining measures, which was a critical publication in our view that offered us a quality lens to look at end-of-life care. And in 2017, as a springboard from this work, I was privileged to be invited to chair a national collaborative on behalf of Canadian Blood Services and the Canadian Critical Care Society that looked at how you might implement those guidelines in the context of DCD. Understanding that the guidelines really spoke very little about donation, except in some small way, and that the relationships that occur at the bedside, the activities that occur at the bedside around WLSM are going to be different and nuanced in that context. We also know that many guidelines will not be implemented because the tools don't exist to implement them, and so part of this workshop work nationally was to bring a pan-Canadian multidisciplinary group together to develop tools that could be used to translate the guidelines into practice. These are the tools that we developed in order at that workshop or before it, and then validated it against the guidelines themselves. There's a documentation tool that clearly documents rationale and dosage of medication that are administered, that is coupled with a WLSM order set. There's a checklist for the practice of withdrawal of life-sustaining measures in the context of DCD, and then there are case and system audit tools that exist to help you look back at your own practice about a single case, or look at your system and see if the infrastructure exists to support quality end-of-life care. In addition to this, we developed a framework for policy that also allows people to develop a WLSM policy in their institution if that's felt to be needed. So 3 main sections of the agenda. The first was really to air complexities and tensions. Turned out that happened for most of the day. The second section was really devoted to thinking about the DCD experience, even going a little farther and redesigning that DCD experience in a way that allowed us to think about the family and patient at the center of that experience, but acknowledge the tensions that exist around the bedside. And then to think about how we might manage change and understand the quality improvement framework that might be necessary in order to implement such a guideline into your own ICU. So Michael Hartwick, who's the moderator today, talks about end-of-life care and donation and has often sort of brought us back to this particular sort of grounding central principle when we come to DCD and WLSM, and that is that organ and tissue donation is an essential component of high-quality end-of-life care, and it is equally important that end-of-life care be of high quality when organ and tissue donation is on the table. I think there are very few people that would disagree with this. Some of this work came from a look at my own withdrawal practice in my own ICU, and so I went back to a patient around mid-2016, and I was curious to see what the documentation would look like if I went back and looked at a single case of withdrawal in my own unit. And so I was at the bedside for that patient. They had a particularly difficult shortness of breath to control. They had a lot of upper airway obstruction and quite a young and distressed family. And so I was at the bedside in that circumstance, and I, in fact, was the one administering the medication. So the charting was not informative. That's what I would say. So the charting read morphine 10 milligrams IV given, morphine 5 milligrams IV given, morphine 15 milligrams IV given, apnea, morphine 10 milligrams IV given. And that was the end of the charting. There actually was no documentation of anything else. You would appropriately push back and say, well, what did you document? And the answer is nothing. And I think about these things, and so I wondered what that might look like in other people's circumstances. And so we encouraged people to think about doing that before they came to the masterclass. So I'll just give you a little historical context. I'll talk a little bit about the complexities and tensions so the panel has something to chew on, and just briefly refer to the guideline work that we've done to date. Understanding that my conflict of interest that I declared at the very beginning should prompt you to criticize me, I think, in putting my hand in the area of WLSM as an organ donation organization chief medical officer for donation. I think it would be appropriate to question that, and so that in fact is one of the tensions that should come out. So in the original 2006 guidelines for DCD, they promoted 4 major principles to ensure that patients' interests are first priority, respect life and dignity of the dying, optimize end-of-life care, and support the grieving family. And I think I often come back to this slide and ask myself, how well are we doing at each component here? And I think if we're reflective, we'll find that we don't quite meet all of those principles all of the time. At the time of the DCD guidelines, there was some caution that existed around, are we ready? Do we have the right prognostication tools? Do we have the right methods to make decisions around withdrawal? And in the context of withdrawal, are we able to separate the tension that a recipient is now waiting, that a family wants donation to happen, and that death would have to occur in a timely fashion? Since the publication of that guideline, donation has increased by 52%, largely on the backs of DCD donation, and I think that we've seen that rise over time. We've seen now implementation of DCD in nearly every province, and I think this is a success story for donation and transplant. But the stakes in the system here are extremely high, and we do, I think, walk a fairly fine line when we think about controversy or crisis in a donation system. And we can think briefly about the crisis that exists in Germany, where an allocation scandal was brought to light about the way in which organs were allocated fairly or unfairly by transplanters. And this is not the withdrawal or care of the donor. This is the transplant recipients, and they suffered an immediate downturn in their donation system and have yet to recover. And that was in 2010. So I think the stakes for our transplant recipients, and to be honest, the stake for public trust in our own care in the ICU is at risk if we don't protect ourselves and acknowledge the tensions that exist at the bedside. So let's talk about those tensions. So when we think about our job as intensivists, Sam Shemy, who you know well, has often said his job is to save life and relieve suffering. And then in donation, it is to protect the interests of the dying patient, and subsequently as a donation professional, to protect the public trust and integrity in that system of donation for Canadians. No light task for a Monday afternoon, for sure. We heard at the masterclass, and every time we talk about this, we hear these issues that are recurrent and we learn something new. So there is this tension that exists between a family who feel they want donation to happen and a medical, ethical, and legal framework that says your goal ought to be excellent palliative care at the bedside. It would be ludicrous to suggest that these things are not passing through our minds, no matter how we protect ourselves or our patients from those thoughts. Questions that came up around when a family says, why can't you simply make donation happen for my loved one who has had withdrawal of life-sustaining measures and who undoubtedly will die? I think we've heard that from both presentations today. The question of could you remove an extraventricular drain, and do you do so in DCD cases, or do you do it in all cases? And the question that happens at the bedside by families simply asking, what are you waiting for? Or by staff who are waiting and watching suffering. There are certainly risks that exist on symptom relief when that's our focus, and that ought to be our focus, of people worrying about the perception of giving too much medication and hastening death for donation, and about the concept of the intent of those medications not being clear, as I showed you in my example. When we look at Ontario, we have data that shows that about a third of patients do not progress to donate within a time that's acceptable. And for us, that's somewhere between 2 and 3 hours, depending on which organs are being evaluated. We heard at the masterclass of the UK example where they wait up to 4 hours and where nearly half do not progress, 44% do not progress. I found that a very interesting observation, one that you could make conclusions on for yourself. What we do here, and what I think Amy will describe during the panel, is this sense of second loss by the family when they're unable to donate. And I think that lots of people around donation understand that concept, but what was striking to me was how complex that was for family and patients and the people that surround the bedside. So we heard a description, multiple descriptions in fact, of this want by the family for donation, of this shift to wanting death to happen in a timely fashion, to fulfill the wish of the donor, and then this sense of guilt for wanting that to occur. We also heard of this immense sense of trust in the healthcare system that occurs by people who consent to donation, understanding we've got a pretty donation-centric audience, a sense that we are doing the right thing by treating symptoms and relieving their suffering. And what was interesting to me was the reflection of how we may contribute to this sense that the gold medal at the end of this process is not a good death or excellent palliative care, but might be donation itself. That maybe the transition is partly our fault, or at least we must own part of that, in saying that when we reflect on the success, do we reflect that the gift is in the consent, or do we reflect on the gift is in any type of donation, even tissue donation, which many patients go on to do? Or are we solely bringing the focus back to organ donation, and that is hurting our families? So I think it's much more complicated than just simply make it happen or relieve symptoms. We have a whole host of people around that bedside with different perspectives, or who are at a distant bedside waiting for an organ to come. We hear the perspective of the ICU and the healthcare professionals around the bedside. We think about the organ and tissue donation coordinator as being the goal, being donation, when in fact often they will describe to us this sense of uncomfortableness. And we heard yesterday that might not actually go away, but your competence at managing that will grow with more experience. We know that there's a transplant program waiting, and we know the families actually feel badly. We're hearing that message, that signal is starting to come out, about disappointing recipients. So we have a job to do here to shift that conversation in some way. I think we have bright lines. There are bright lines here. We can talk about philosophical ideas or what's moral and what's ethical, but there are bright lines, and one of the things that's a bright line is the criminal code, for example. So we can't expedite death in these circumstances. Our focus has to be on relieving suffering and preserving the public trust. Some work has been done on this. I find the conclusion of this study very interesting. They talk about a gray area in end-of-life care between treatments being administered to relieve pain and suffering and intending to shorten the dying process. This is a one-center look at comparing that data in less a robust way than we're hearing today. But is there a difference between DCD patients and non-DCD patients and how quickly they die? And I find these analyses interesting, but often very confounded. So yesterday we learned about, I think, a very vocal, genuine desire to honor the wish of the donor. That comes out from professionals across all components here, and it comes out from the family members. But we also heard about a tension in being unable to do that in some circumstances. And I think it's important to understand that maybe our relief of that tension is refocus, is a sense that it's not always going to be about organ donation. It's about comfort and that their gift was in consent, which might be false reassurance for the donor family. We heard importantly about how trust is built, excellent care, respect for the lines that we have, doing what's right. And we heard about no surprises and thinking about what the family are going to experience in a very honest and genuine sense at the bedside. So just briefly, from the work that you've heard, the work of the Canadian Blood Services group to come up with an ethics guide for organ donation-focused physicians that might help us, guide us in this way, also endorsed by the Canadian Medical Association. We know that in the original guidelines, much to what Jason was referring, we should establish safeguards in the withdrawal of life-sustaining measures process. This guideline itself actually highlights on the very front page as the take-home message that these guidelines can help provide high-quality end-of-life care by balancing the medical, legal, and ethical considerations that no doubt would be higher and elevated during the concept of donation. So from this work, we defined what high-quality end-of-life care was at that meeting in a way that helped us structure that, maintaining dignity, respect, and compassion. And I think you'll hear from the panel today about the wishes and voices of the patient, observing control over what they can have control over, providing comfort consistent with the guidelines, and adhering to the medical legal framework that exists for us while preserving the opportunity to donate organs and tissues. So these were the tools that came out of that knowledge translation workshop. And I want to just emphasize one of the comments that came out in the class yesterday, because I couldn't have dreamed of someone writing this in a better way. So why would you implement these guidelines? Why would it be okay for an organ donation organization to come out and say this is really important to protect the system? And if you look at the pink writing, protects ethical safeguards for all WLSM with standardization, transparency, and accountability. And it translates the experience of dying to be viewed through a lens of quality. Now that's a task that we could take on with significant effort. Trillium has made strides forward. We see these tensions and are hearing about them at the bedside. We asked hospitals to look at their practice and think about an order set and documentation tool. We're about 3/4 of the way through that plan, and we're stuck at this point, actually. We've got a little bit of resistance now. We are hearing from people that maybe it's not actually the role of the hospital donation physician to look at WLSM. From the class yesterday, I think the message was that we're all a team, and we all share in that experience, and I think that's really critical. We have impressively, with the team at TGLN, many of whom are here, completed most of the audits. In fact, now almost 90% of the audits have returned to highlight the gaps. And so these may not be gaps that need to be closed at every hospital. I'm not suggesting every hospital needs a WLSM policy, but you can see that the rates of that are pretty low. The huddle or responsibility checklist was about 2/3, specific documentation tool about 1/3. That doesn't address current documentation tools that might meet the need, and then a pre-printed order set in 60%, which doesn't address utilization. So I hope that I've set the panel up for a discussion around the environment that surrounds the potential donor following consent to withdraw invasive support, and acknowledges the tensions that exist for us. I really do believe the implementation of the guidelines will help us at the bedside give us some relief from that tension, or at least be able to openly acknowledge it and discuss it in a framework that makes sense to everybody. Thank you.